Welcome to the Deep Dive. We're the show that takes a whole heap of information articles, research, you name it, and boils it down to what really matters for you. Today we're diving into tranexamic acid, or TXA. You've probably heard about it. Often gets called a wonder drug, yeah. Especially for serious bleeding, like in trauma. But the big question we're asking is, does it really deserve that label? For all bleeding? Or maybe even any bleeding?
That's exactly it. That's our mission today. We want to cut through all the hype, look at the, often contradictory studies, and give you a really solid, calibrated sense of when TXA actually works, and maybe more importantly, when it really doesn't. We've gone through a pretty big stack of sources, the major trials, the analyses, basically, to give you a shortcut to being properly informed on this.
Okay, so let's start right at the beginning. What actually is TXA? How does it work? The full chemical name is a bit much transaphorimonomethyl glycosidic carboxylic acid. Yeah, we'll stick with TXA.
Definitely TXA. So the mechanism is kind of neat. Imagine your body makes a blood clot, right? Like a little dam to stop bleeding. Well, your body also has a system to break that dam down later. TXA sort of pauses that breakdown. It latches onto this thing called plasminogen, stops it becoming plasmin. And plasmin is what dissolves those fibrin clots. So TXA basically helps your natural clots stick around longer. It also seems to have some anti-inflammatory effects, which is why people talk about it for like angioedema too.
Got it. So now we know what it is. As I was looking through all this stuff, I noticed this pattern. You see it a lot in medicine, but it feels really strong with TXA. You get these small studies, everyone gets excited, wow, this works. And then the bigger, maybe better studies come along, and it's kind of a letdown. Why does that happen so often?
That's a really key point. It gets down to some basics of, well, how we should read medical evidence. First off, there's something called pretest probability. Basically, when you see a new study, you don't start from zero, right? Your interpretation depends on what you already know. Like if a study says a new painkiller works, okay, plausible. If it says, I don't know, lemon juice cures cancer, your starting belief, your pretest probability is super low. Most new things actually fail rigorous testing. And the second big issue is getting carried away with subgroup analyses or secondary outcomes. Think of it like the lottery. Buy one ticket, tiny chance, buy millions. Someone's going to win just by luck. It's kind of the same here. Run loads of different analyses on little subgroups or less important outcomes. You increase the chance of finding a statistically significant fluke. That p less than 0.05 we hear about, it still means a 1 in 20 chance it's just noise, which is honestly pretty weak evidence compared to other sciences. Physics wants like p less than 0.000000, and one review looked at 64 big trials. Only 10% of their exciting subgroup findings were even studied again. And guess what? Not a single one held up.
Yeah.
Zero.
Wow, zero.
Yeah. Which leads straight to the third point, replication. It's the absolute bedrock of science. The only way to be really sure is if different people can get the same result independently. Even massive, well-run trials can be fluke sometimes, or have subtle biases. Replication helps sort the real findings from the noise.
Okay, that framework is super helpful because now we're going to look at TXA for specific things. And yeah, you really see these patterns. Let's start with surgery. Using TXA to reduce bleeding during operations seems obvious, right? And there are tons of studies.
Oh, absolutely tons. Like 252 randomized trials over 25,000 patients. It's a staggering amount of research. But, and this is a big but, a lot of those studies are tiny, like 10, 20 patients per group, maybe 100 in the biggest ones. When you pool it all, yeah, there's a signal. TXA seems to reduce blood loss during surgery, average around 247 milliliter. And it reduces the need for a transfusion by about 18%.
Okay, so less blood loss, less need for transfusion. Sounds good so far.
It does, but here's where it gets tricky and why wonder drug might be pushing it. Even though it reduced the need for transfusion, it didn't actually change the total amount of blood patients received. And crucially, no difference in the things that really matter to you, the patient. Survival rates, chances of having a heart attack or a stroke or serious clots like DVT or PE, no difference. Didn't even change the rate of needing a second operation to stop bleeding.
So it changes the lab values, sort of, but not the patient's actual outcome.
Pretty much. And adding to the uncertainty, a lot of those smaller studies had significant issues. Risk of bias. Some even kicked out patients who bled a lot afterwards, which obviously makes the drug look better than it is. And there's clear publication bias. Small positive studies get published, bigger negative ones maybe don't. Look at the ADA case trial, huge study, over 4,600 heart surgery patients. No difference in death or clots. It did find fewer returns to the OR for bleeding, a secondary outcome, but, and this is important, it increased seizures, 0.7% versus 0.1%.
Increased seizures, wow.
Yeah. And it reminds you of aprotinin, another similar drug. It looked like it reduced bleeding even more than TXA, but it got pulled because there were concerns it actually increased deaths. It's a huge warning about focusing just on bleeding volume if it doesn't make patients better, or worse, makes them sicker.
That's a really powerful example. Okay, from the OR to the gut, what about TXA for GI bleeds, gastrointestinal bleeding? This seems like a case where science kind of progressed, right? From early hope to clearer answers.
It really is a textbook example. Early on, you had a 2014 review, 8 small trials. It hinted at lower mortality. But even that hint disappeared when they properly accounted for patients lost to follow-up. The authors of the biggest early trial even said, look, biologically, it doesn't make much sense for it to reduce deaths if it's not changing bleeding or surgery rates. Then came H. Halto, updated in 2020. Massive international trial. Over 12,000 patients, mostly upper GI bleeds. The result: absolutely no benefit from TXA. Zero. No change in death from any cause. Death from bleeding, rebleeding, surgery, endoscopy, need for transfusion, amount transfused. Nothing.
Nothing at all.
Nothing good. But here's the kicker. The only statistically significant difference was actually harm. It doubled the rate of serious blood clots, VTEs, from 0.4% to 0.8%. So the bottom line here is crystal clear from the best evidence. TXA should not be used for GI bleeds. It causes a small net harm.
Wow. Okay, so definitely not for GI bleeds. That's
Yeah.
sobering. How did those early stories get so much traction then? All right, next up, postpartum hemorrhage, PPH, severe bleeding after having a baby. This feels like a place it should work, but the evidence sounds complicated.
It is complicated, yeah. The big study here is the woman trial, huge again, over 20,000 women globally, and its main finding: no difference in the primary outcome, which was death from any cause or needing a hysterectomy. Overall mortality was basically identical, 2.3% with TXA, 2.6% without.
So no difference in overall survival.
Right. But then there was this secondary finding that got a lot of attention, a small drop, 0.4%, in death due to bleeding. But you have to be really careful with that. If the drug isn't saving more lives overall, then saying it reduces deaths from one specific cause might just mean it's increasing deaths from other causes to balance it out. It's potentially misleading.
Okay, I see. So focusing on death due to bleeding can hide the bigger picture if overall death rates don't change.
Exactly. And other studies in PPH are kind of murky too. The TAP trial looked at using TXA to prevent PPH after vaginal delivery. Found no difference in significant blood loss, transfusions, surgery, nothing clinically important. Then TAP2 looked at prevention after C-sections. It did have a positive primary outcome for TXA, but it was based on an estimated blood loss difference of just 30 millipar, like a couple of tablespoons. Clinically meaningless. And again, no difference in transfusions, ICU stays, hemoglobin levels. But TXA did increase nausea and vomiting. So yeah, the overall conclusion right now is that TXA doesn't seem to routinely help in PPH. Maybe those secondary findings need more research, but for now, it's not a standard of care lifesaver. Perhaps in really catastrophic bleeding, but not routinely.
Right, okay. Moving from childbirth to bleeding in the brain, non-traumatic intracranial hemorrhage, ICH, and subarachnoid hemorrhage, SAH. Does TXA help there?
Here, the evidence is actually quite strong, and it's clearly negative. The TICH2 trial, big, high quality, over 2,300 patients with spontaneous ICH. Found no difference in functional outcome at 3 months, no difference in survival. There was a tiny statistical difference in how much the bleed grew, like 3.7 millimillar versus 4.9 millimillar. Think less than a teaspoon difference, clearly not clinically relevant for the patient.
So basically no meaningful benefit for ICH. What about SAH?
Same story, really. Big reviews, the ULTRA 2021 trial, all found no significant difference in functional outcomes or overall mortality for subarachnoid hemorrhage. Now, TXA did reduce the rate of rebleeding in SAH, that sounds good, but that benefit was completely wiped out by a significant increase in cerebral ischemia, basically reduced blood flow causing brain injury. So you trade one problem for another with no net benefit, maybe even net harm. The bottom line is pretty straightforward here. Strong evidence, clearly negative results. No role for TXA in non-traumatic brain bleeds.
Okay, that seems quite definitive. What about something super common, like nosebleeds, epistaxis? Any magic there?
You'd hope so, wouldn't you? It's such a common problem. Early, smaller studies hinted maybe it reduced rebleeding, but again, no evidence it changed important things like needing transfusions or packing. Plus, study quality concerns. Then came the Unpacked trial in 2021. High-quality, multi-center, nearly 500 patients whose nosebleeds didn't stop with first aid. And no difference. The main outcome was needing anterior packing, snuffing the nose, no difference at all. No difference in needing other treatments, hospital admission, transfusions, or recurrent bleeds later. So the best evidence we have now suggests TXA doesn't really help with nosebleeds either. Not the quick fix people were hoping for.
Seems like a recurring theme. Are there other areas where TXA has been tried, maybe with less solid evidence either way?
Yeah, quite a few, and mostly the story is similar. Small studies, hints of maybe changing some measurement, but no clear patient benefit, or just inconsistent results like tonsillectomy. Maybe reduces blood loss by a tiny bit, like 30 millikils, but doesn't change the risk of a serious bleed or needing more treatment. Dental bleeding, very limited data. Topical TXA might reduce bleeds needing intervention after extraction, but wasn't better than just gauze pressure. No good evidence for active oozing in the ED. Hemoptysis, coughing blood. Small, biased trials hint it might stop bleeding faster, but results are all over the place. Really needs a big, proper trial. One retrospective study claims survival benefit, but lots of limitations. Hyphema, I bleed. Small studies show it reduces rebleeding in the eye. Sounds good, but crucially, no effect on vision. Didn't help people see better, and there's a worry it might increase glaucoma risk. Needs a big trial. Dysfunctional uterine bleeding, low quality evidence. Suggests maybe a small decrease in monthly bleeding, some symptom improvement. The studies are small, often unblinded. Very shaky ground, given how often these findings evaporate in better studies. Post-circumcision bleeding. Seems plausible, but believe it or not, no studies currently available.
So a lot of maybes, question marks, and needs more research. But now, let's get to the big one, trauma. General trauma and isolated head trauma. This is really where the TXA legend started, isn't it, with the CRH2 trial?
Absolutely. CRH2, published back in 2010, was the game changer. Massive trial. Over 20,000 trauma patients with significant bleeding. And it showed a 1.5% absolute reduction in all-cause mortality with TXA. It saved lives. The number needed to treat NNT was 67. Treat 67 bleeding trauma patients, save one life over 28 days. That's, pretty significant in trauma care.
Okay, 1.5% mortality benefit. That sounds like the real deal. But are there catches?
There are definitely important caveats. For one, CRH2 didn't decrease how many patients needed transfusions or the total amount of blood they got, which is weird, right? If it saves lives by stopping bleeding, you'd expect transfusion needs to go down. So the mechanism of benefit isn't perfectly clear. There were also concerns about tracking blood clots, VTEs, especially in some of the lower resource settings where many patients were enrolled. Maybe they were underreported. And is the result directly applicable to, say, a super high-tech trauma center in the US or Europe? Maybe. Maybe not entirely. The context was different for many patients in the trial.
Okay, so questions about how it works and maybe generalizability. What about other trauma research?
It's been mixed. The STAMP trial looked at giving TXA before the hospital, pre-hospital TXA. No difference in 30-day mortality found there. Then you have observational studies like Matters and Cole 2015. People cite them a lot. But you have to be careful with observational data, lots of potential for confounding factors. They aren't randomized trials. Matters showed lower mortality with TXA, yes, but also more blood clots and, weirdly, higher transfusion needs. Cole 2015 showed similar death rates early on, but actually higher death rates after 48 hours in the TXA group. So not exactly a clear picture supporting TXA there.
And what about just head trauma on its own?
Right, isolated head trauma. That was CRH3, another huge trial, over 12,000 patients, published in 2019. The result, no change in overall mortality and no change in neurological outcomes. Didn't help people recover better from the brain injury. Now, there was a subgroup analysis that looked promising for head injury-related death in patients with mild to moderate injuries. But remember our chat about subgroups, and a big meta-analysis specifically on TBI concluded TXA probably has no effect on mortality or disability. So overall, for trauma, British 2 is the best evidence we have, suggesting a mortality benefit in bleeding trauma patients, but science needs replication, and other evidence is mixed or negative. Courage 2 really stands out as the only large, high-quality trial showing that clear all-cause mortality drop for any indication. Makes you wonder if it's an outlier.
Right, that replication piece seems key. Okay, beyond if it works, when should it be given? And what are the risks? Because nothing's risk-free.
Exactly. That whole earlier is better idea mostly comes from another subgroup analysis in CRASH 2. It suggested benefit if given under 3 hours, but actually harm, increased mortality if given after 3 hours. But that pattern wasn't seen in HALT-IT, TESSI 2, or CRASH 3. It's inconsistent. And it's that subgroup issue again. If you believe the early benefit based on that analysis, you logically have to accept the potential for later harm too. You can't cherry pick.
Makes sense. And safety overall.
Generally, TXA is considered relatively safe. Compared to many drugs, it is. But anything with real effects has side effects. We touched on mortality. If a drug reduces death due to bleeding, but not overall deaths like in Woman or CRASH-3, it implies it might be increasing deaths from other causes. That's a potential harm you accept if you focus only on the disease-specific outcome. The big safety concern, though, is probably blood clots, VTEs. we saw the risk was doubled in haltis for GI bleeds, 0.4% to 0.8%. The observational matter study suggested much higher risk, though again, observational data caveats apply. While other big RCTs haven't consistently shown this VTE increase, there's a theoretical worry. TXA might mess with D-dimer tests, potentially masking clots. So even if the clot risk is small, it matters a lot if you're giving the drug for something where it doesn't actually offer a clear life-saving benefit, like maybe PPH, where overall mortality was unchanged. Other things reported are low blood pressure if given too fast, rare strokes, and those seizures we mentioned, particularly after surgery.
Okay, wow. So let's try and pull this all together. After going through all this evidence, it seems pretty clear TXA is definitely not the universal miracle cure it's sometimes made out to be. We've seen way more high-quality trials showing no benefit or even hints of harm than positive ones. TRACH2 really is the main exception.
That's exactly right. That's the core takeaway. Most of the wins for TXA are in things like blood loss volume, these disease-oriented outcomes, and they often come from smaller, lower-quality studies that, as we've seen, frequently don't hold up. CURE-H2 remains this significant outlier showing an all-cause mortality benefit, which is why replication is so crucial in science. We need to be sure, especially when so many other large, well-done trials in different areas, GI bleed, PPH, brain bleeds, head trauma, came back negative or mixed.
So what does this mean practically for you, the listener, or for clinical practice now?
Well, based on everything we've looked at, TXA is still generally used for bleeding trauma patients, largely based on CURE-H2. But importantly, it's not typically used for isolated head trauma, spontaneous brain bleeds, or subarachnoid hemorrhage. The evidence is strongly against routine use in GI bleeding and postpartum hemorrhage. And for nosebleeds, the latest data says it doesn't really help. Overall, it seems TXA probably has a very small effect, if any, across most situations. It likely shouldn't be used routinely for any indication outside of that CRSH2 context, arguably. The harms are real, though generally small. Clots are the main worry, maybe. For some select patients with really severe bleeding that just isn't stopping with anything else, it might still be reasonable to try it, kind of as a last resort while we wait for more research, but routinely. The evidence just isn't there for most things.
So a much more nuanced picture than wonder drug. As you think about this journey with TXA, here's something to ponder. How might really understanding this need for replication and being aware of these common study pitfalls like subgroup hype change how you look at claims about breakthroughs or miracle cures in other parts of your life? Not just medicine, but anywhere you encounter new information.